to this session of the new session of the NOEL. As all of you are aware, this NOEL session is running for the last 4 years successfully. And today's session is the 23rd session of the 4th edition. And we do in the format, we do case presentation and some of the guest lecture. So here today's presentation is a case presentation of a RH negative pregnancy and its consequences as a jaundice and challenge in managing management and learning points. So today to present this case, Dr. Swati, NNF fellow from Cloud9 Bangalore, she is there. She is going to present the case, and their team and the faculty, Dr. Prasanna Munyappa. He is a leading pediatrician and neonatologist of Cloud9 branch in Bangalore. So he has moderated already, helped for presentation and what are the learning points. So the presentation will focus, Dr. Swati probably discussed well. So we are expecting some of the good learning points today in a challenging case of RH negative pregnancy. And to ability to moderate, we are privileged to get two of the faculty neonatologists, Dr. Swarup Das. He is a neonatologist who is having a 10 to 12 year of experience in a tertiary level NICU. With after a DRNB neonatology course, he is practicing neonatology for 12 years in a tertiary level, experience in Dubai, intensive care in tertiary level, and Surya Hospital, Mumbai now. Is able teacher. So we'll hope that throughout the session, he will guide the audience, the delegates, and Dr. Swati for the learning further. And Dr. Rita Bara Madam is professor and head of the Assam Medical College Department of Pediatrics. She is a well-known neonatologist across India and specifically to the east part of the India, very well-known figure in neonatology and a senior teacher. Many of the sessions we attended her session we attended before. So we hope that is a vibrant, dynamic discussion today to learn from a simple case what are the which we face many a times, what are the challenges Dr. Swati and team face and how they manage the case and what the learning point for today. So Dr. Swati, I will request now the time is yours, next 45 minutes. You can present and both the faculties, I welcome to the session and request them to go ahead with the discussion. And I will be a silent spectator. And lastly, probably, I will summarize the learning points at the end of the session. Thank you, all the faculty, three faculties.
Thank you very much.
Invite Dr. Swati to go ahead. In the meantime, any of the faculties, Dr. Prasanna, Dr. Swarup, or Dr. Rita ma'am, any of the three, you want to put some lines here to for the audience also what we are expecting, you can do that so that the presentation can start. Otherwise, the later part also you can give your inputs.
Yeah, it's okay from my side. So you can start.
So yeah, you can go ahead the presentation. All faculties giving a green signal. Dr. Swati.
Yes, sir. Good evening, everybody. Today I'm presenting a case of baby of XYZ, singleton, early term, 37 plus 4 weeks, a female neonate with a birth weight of 2,840 grams, born at Cloud9 Malleshwaram on 10th February 2024 at 11 a.m. by emergency LSCS in labor, and that was because of previous LSCS. And coming to the antenatal history, it was booked. It was this case was booked elsewhere, and the mother was G2P1L1 with 37 plus 4 weeks with RH negative pregnancy, and G1 was a female baby born through LSCS, and blood group of this baby was B positive, and baby had received anti-D. Mother had received anti-D during this pregnancy, and baby had received DSPT on day 3 of life. G2 is the present pregnancy. It was spontaneously conceived. And the present pregnancy, the first trimester was uneventful. And the second trimester, mother had taken calcium and iron supplements, and also 1 dose of Tdap was taken. And during second trimester, anti-D was advised, but parents have refused. And mother's blood group was B negative, and the other investigations done during pregnancy was reported as negative. And ICT done during pregnancy was negative, and NT scan was normal, and anomaly scan also was normal. And MCA Doppler that was done in the beginning of third trimester scan was normal, but thereafter we don't have any scan reports available. And the labor and delivery, the spontaneous onset of labor and emergency, baby was born through emergency LSCS, and baby cried immediately at birth. DCC was done for about 1 minute, and routine newborn care was given. Apgar score was 1 by at was 8 by 10 and 9 by 10 at 1 minute and 5 minutes, and the vitals remained normal. And baby was shifted to mother's side. At birth, in view of Rh negative pregnancy, baby's DCT and blood group was done. DCT came positive, and the blood group of the baby was.
So, Dr. Swati,
Yes, sir.
just I will request to hold on this presentation. We
Yes, sir.
covered antenatal, we covered labor and delivery. So
Mhm.
I will request the faculties. So initiate the discussion. If any specific history are we missing in the antenatal or during this course, antenatal history or perinatal, can we go with the exactly plan with this history, or we need some more specific history or any relevant history are we missing? Both the faculties I will request to initiate discussion.
Yeah, so Swati, I'd like to know for how long did the first baby receive phototherapy, and do you have any idea what was the maximum level of serum bilirubin?
First baby had not received. Baby didn't have any history of prolonged jaundice, ma'am. So on day 3 of life, baby had received DSPT for
Okay,
about
for 1 day. That means around 24 hours.
yes, ma'am, about 24 hours.
Okay, and the level might have been something like not very high.
Yeah, it was in the phototherapy range, but not
But
very high.
the pregnancy, sorry, baby, the mother received anti-D in the first pregnancy.
In the first pregnancy, mother has received anti-D.
Okay,
Okay.
go ahead.
And like in the history, you also had mentioned that there was delayed cord clamping
Yes, ma'am.
with
Yeah,
pregnancy.
yeah.
So can you give us some information like what is the evidence of delayed cord clamping for Rh negative pregnancy? Is there any evidence?
Right now, there is no contraindication for delayed cord clamping in Rh negative unless there is a fetal hydrops, which is noted antenatally, ma'am.
Okay,
Otherwise,
any
PCC
like
can be done.
yeah. So this information which you are giving, is it based on any evidence?
That I'm not sure, but
Yeah, so we have one study from our own country, and that is the only study which has been done on delayed cord clamping in Rh negative pregnancy. And this was from AIMS Delhi by Tanushree Sahu et al. So
yes,
maybe like you would like to go through it. So this is the only study which has been done on Rh negative pregnancy, and they had found that delayed cord clamping is rather helpful in Rh negative pregnancies also because it leads to increase in blood volume. But then there is no ill effects. So you are very correct in saying that there is no contraindication of delayed cord clamping even in Rh negative pregnancy. Yeah.
yes. At birth, there is
Dr. Swati, Dr.
yes, ma'am.
Swati, from my
Yes,
side, one simple question.
yes, sir.
Simple question,
Yes,
which can be sorted out in history sometimes.
yes, sir.
A mother we know B negative or O negative or RH, any form of negative. Now
Yes,
the
sir.
NTD given, if without knowing the fetus blood group, I am giving NTD, I am giving probably 30% to 25% to 35% NTD when not required actually. Okay. Because the baby, chances of baby also negative is there is a possibility. So
Yes, sir.
many of cases which is seen
Mm.
that in case if we don't know the fetus, we know after the umbilical cord blood grouping only for the baby. So you
Yes,
have rightly told it's a female baby, we positive, so they've given later. But what the
yes, sir.
history or antenatal assessment you will like to do, which will prevent this excessive use of anti-D when it is not needed. It is indicated, justified to go ahead. But if you are giving antenatally, postnatally justified.
Right.
Antenatally, if we want to give to the mother, what history will tell you, okay, there is this history is there, I need not give anti-D, or particular this investigation I will do antenatally, I need not give the anti-D to the mother.
A paternal blood group.
Very good. Very good. So I'm happy. So we probably have to ask that in the history we have to include. So did you include that history? What is the father's blood group?
Yeah, father's blood group was positive, sir. A positive. B positive.
Okay. So
B positive.
is it there in your history taking?
Yes, sir. Father's blood group was positive blood group.
Okay. So always it is, we have to remember if it is a both parents are negative, So then we got many things excluded from the system. So that history is very important to get a paternal mother blood group history. And currently, there is a way from the maternal blood group we can know the baby's fetal blood group also we can know. We need not do invasive testing.
Yes,
By
sir.
doing the fetal blood grouping from the mother's blood sample, we
Yes.
will know that the baby also negative. We can avoid these all extra evaluations. Only just clinical monitoring is needed, but extra evaluations and entity we can avoid. So that's my point actually. That's the point of learning point. So with history, simple thing, but by asking one extra question, we can avoid few things here. Okay, Dr. Swati, you can proceed with the presentation further.
Okay, sir. At birth, in view of Rh negative pregnancy, baby's DCT and blood group was done. DCT was positive and blood group, there's a mistake. I apologize for that. B positive. And SBR at birth showed a 16.10 and direct was 0.5, in view of which we had started TSPT. And the baby was also started on continuous NG feeds.
Okay.
And we.
Can I just interrupt here?
Yes,
So
yes,
you
ma'am.
said that the first baby did not have severe jaundice, and
Yes.
then mother had also received a dose of anti-D.
Anti. Yeah.
Yeah. So now, what may be the reason for this DCT coming positive in this baby?
Probably because anti-D was refused at 28 weeks of gestation.
So mother had received it postnatally in the first pregnancy, isn't it? So you
Yeah.
don't think that this is because of this baby's blood going into the mother profitomaternal hemorrhage,
Hemorrhage could have happened.
or like there are other reasons also? Can there be any other reason? Yeah. So maybe the amount of, anti-D which was given to the mother was not sufficient for the fetomaternal bleed that had occurred during the delivery of the first baby. That can also be true, isn't it?
Yes, yes, ma'am.
Yeah. Yeah, you can continue.
Okay, and at the same time, we had done CBC peripheral smear and retic count, which revealed hemolysis. So we had started on folic acid on at birth itself. And so the features of hemolysis we saw here was the retic count was 9.8, so reticulocytosis was there, and increased bilirubin was there. And then in peripheral smear, we had seen anisocytosis, and microspirocytosis also was seen. And thereafter, we started the baby on TSPT and continuous NG feeds, and we had done serial monitoring of SBR. So about 12 hours of starting the TSPT, we had again repeated the SBR, which came 15.9. So we have used this chart, that is AAP chart, which is the exchange transfusion in newborns more than or equal to 35 weeks. That chart was used, and then we had plotted it at birth. It was in the exchange transfusion rate, and again at 12 hours we had again repeated after starting TSPT. So that also came in the exchange transfusion range. So at that time we had given IVIG.
Yeah, just I want to interrupt.
Yes.
In I7 hemolytic anemia, what is the role of IVIG? Current concept.
The evidence says that IVIG is not recommended.
Yeah.
There is weak evidence, moderate to weak evidence, for the role of IVIG in preventing exchange transfusion.
Yeah, actually, there is very little role of IVIG in the current concept. Tell that very little role of IVIG in I7 hemolytic anemia. In fact, actually, it can cause sometimes some complications like an AC.
NEC, yes.
Yeah, yeah.
Yes.
Go ahead, please. Yeah.
Yes. And then again at 24 hours, we had after IVIG, we had repeated SBR at around 24 hours of life, and it was plotted again here, and it was way above the exchange transfusion range. So we had given double volume exchange transfusion was done at 24 hours of life. So, and again, we had serially monitored for SBR after the exchange transfusion. So we noted that there was gradual reduction in the SBR levels. But at around 40 hours of life, there was increase in the SBR levels again. There was rebound increase in the SBR. So we had given second dose of IVIG, but immediately at 48 hours of life, we had repeated again after the second dose of IVIG. We found that the SBR had increased to 23. So on the graph, it was way above the exchange transfusion range. So we had given the second dose of second double volume exchange transfusion was done. Thereafter, we have serially monitored the SBR values, and it's been remained below the treatment range, below the exchange transfusion range, but phototherapy was being continued. So we had followed the AAP chart for the exchange transfusion levels. So baby almost remained, the SBR values almost remained normal at 72 hours of life, remained below the exchange transfusion levels. And post transfusion, post exchange transfusion, we had repeated certain blood investigations which revealed hypocalcemia, and baby also had symptomatic hypocalcemia in the form of jitteriness. So we had started calcium correction, and then we had repeated the calcium values, and then the baseline was 1, which was normal, and then after the transfusion there was a fall in the calcium along with the symptomatic presentation, and then we had given correction, and then calcium was in the normal range. And this was again at 42 hours of life. In 48 hours of life, we had given we had done exchange transfusion for the second time, and we had done the bind scoring for the baby, and the bind scoring was 0. And before starting exchange transfusion, ultrasound cranium was done, which was normal. And we had done Guthrie was done, pre-transfusion Guthrie was done, which was normal. And so after the second transfusion, the subsequent SBR showed a reducing trend. So we had shifted the baby to wards with DSPT on day 5, and the baby was discharged on day 7 of life. Bera was done before discharge, that was normal, and baby received all the vaccinations before discharge. And baby was followed up on OPD basis, and folic acid was given for about 6 weeks, and the developmental milestones right now is appropriate for age. And this is the blood investigation. So initially at birth, when we did HB was 13.5 and PC was 36, and retic count was 9.8, which showed signs of hemolysis. And thereafter, after transfusion, there was improvement. But post transfusion, there was a thrombocytopenia seen, that was 0.25, and after that we had transfused platelets, and then there was improving trend. And we are also done left. Yeah. Yes, ma'am.
Yeah, can you just let us know the reasons for this total count being so high, 38,000 on the first day?
Any kind of stress can also cause increase in.
Yeah. And how about the platelet count?
The platelet counts at birth remained normal, but thereafter there can be there was a thrombocytopenia. It can be because of a complication of exchange transfusion, or it can be sometimes in hemolytic anemias also we can see thrombocytopenias.
No, but like in this patient, there is definitely hemolysis. But what may be the cause for thrombocytopenia? In hemolysis, why there is thrombocytopenia?
Because there will be reticulocytosis, and so that's why there won't be there will be thrombocytopenia, because they come in the same line. So because of reticulocytosis, all the supply in the bone marrow is going through to the reticulocytosis and the thrombocyte.
So it's like hyperactive erythropoiesis with
causes
other
thrombocytopenia.
series. Yeah.
That's the reason maybe the WB7, the total leukocyte count showing high, because maybe lots of nucleated RBCs are there in the blood. Somebody pointed out already, I mean, in the discussion page. That's the reason maybe that's sometimes you have to do the nucleated RBC count. So you can adjust the total WBC counts.
Okay.
And LFT, serum albumin was always normal. This about LFT.
The LFT was deranged.
Yeah, the SGOT, SGPT was slightly deranged.
Okay, can you tell us why it was so?
I mean, we have repeated the LFTs that has remained normal now.
So initially it was on 10th, you have mentioned as 146.
Yes, yeah. At birth, it was mildly deranged. SGOT is 147, SGPT is 107.
So did you find any reason for this? Okay, you can go carry on.
Okay. So this is about case. So this is about the exchange transfusion. Can I go ahead with the?
Yeah.
Dr. Swati,
Yes,
just
sir.
a little interruption here
Yes,
during your presentation only.
yes,
Two things. One, again, one of the trainee now asking question, why thrombocytopenia? He did not understood why thrombocytopenia. That's one question you can explain, or will try to explain one thing.
yes,
Second thing is, I am asking actually a case where RH negative, you have RH negative double volume exchange transfusion you have done. Now you are getting thrombocytopenia. So are you worried about other comorbid conditions to rule out you will look for?
Mm.
A newborn baby. So you
yes,
got a exchange transfusion is a procedure, invasive procedure you have done. Now
yes.
after the procedure, you are seeing there is a progressive thrombocytopenia. So are you interested to look for other comorbid conditions also?
Yes, sir.
Common conditions I'm asking. I'm not asking very rare thing to you, but you are a trainee who bedside doing the things. So if next day if thrombocytopenia,
It
so
can be because of sepsis after
yeah,
post
yeah.
procedure.
Yeah, perfectly fine. That's my point here. But the why now we'll come back actually. So sepsis can cause thrombocytopenia. So post-section transfusion, mild hemolysis, we see thrombocytopenia. But why in hemolysis when there is ongoing hemolysis, which is the current scenario, we get little thrombocytopenia? That was the question asked again. One of the training. Can you clarify once?
Yes, sir. Because what happens is whenever there's hemolysis, there's reactive reticulocytosis. Because of reticulocytosis, they come from the same line. So there will be thrombocytopenia also, sir.
Rather than saying reticulocytosis, I think you should be saying erythroid hyperplasia.
Oh.
Okay. So because of erythroid hyperplasia, the other cell lines would not get the chance to proliferate. Like the body is concentrating more on production of erythroid cells.
Yes, yes.
So there is relative thrombocytopenia.
Dr. Swati, I will give you example. A
Yes,
IUGR baby who is compromised for long in utero,
yes, sir.
hypoxia, if there
Yes.
is a polycythemia, what happens to the thrombocytes? If I will give erythropoietin for stimulating hemoglobin, where the erythroid cells are increasing, what happens to thrombocytes?
They reduce.
Reduce. I will give erythropoietin to improve the erythrocytosis. Do you think there will be thrombocytopenia?
Yes, sir.
Erythropoietin, it will increase. Erythropoietin, same cell line, it will increase actually the platelets also. So if you can see many times, you see polycythemia, all the cell lines also goes up sometimes. So what one point we are clearly highlighting, if there is acute increase in cell lines, erythroid cell lines, there's a competition for this resource. So there will little platelets will be low. But more than that, the more important part happens, the peripheral destructions. When there are hemolysis, ongoing hemoglobin release, there is a clumping of platelets happens in periphery. So the two factors here, competition in erythroid group, so little depression in the thrombocytes possible, but not that's not the commonest mechanism because anything which stimulates erythropoiesis partially stimulates thrombopoiesis also. But due to the peripheral congestion, when ongoing hemolysis is happening, peripheral activation of congestion and coagulum formation, the platelets counts the clump counts decreases. Clump formation happens to decreases the platelets due to peripheral activation of the clumps. So that's the measure mechanism. The other mechanism, bone marrow also, you are right there. So these two things to be explained when we see ongoing hemolysis time, we see thrombocytes. When some immunological phenomenon independently there also, that not here, sometimes thrombocytopenia, we do DCT to know that there is the immune background, some immunoactivation, immune hemolysis happening. So hemoglobin also low, and there's a peripheral destruction. Parallelly, there's a destruction of platelets also happening. So DCT positive time, we say common immune phenomenon, that's also might be responsible. Okay. So we can proceed further. In anything clarification, faculties can go ahead, or you can proceed. In the meantime, we are taking the questions. Whenever relevant questions will come, we will interrupt and we will discuss again that part.
Go ahead. Yeah.
Okay, we are done with the case presentation part. So now is the discussion part. So first thing is the exchange transfusion. Exchange transfusion is a process where we remove the aliquot of the patient's blood and we replace it with a donor blood. So thereby we are removing any kind of abnormal blood components and circulating toxins, and also maintaining the adequate circulating blood volume throughout the process. Indications for exchange transfusion would be severe hyperbilirubinemia secondary to alloimmune hemolytic disease of the newborn. That's the most important and most common cause. The second one can be significant unconjugated hyperbilirubinemia with risk of kernicterus due to any other cause when intensive phototherapy is unsuccessful. And any antibodies in the maternal autoimmune disease also can be one of the indications. Polycythemia and any disturbances in the body chemistry also. So here we can see we have an umbilical vein, a catheter which is put, and then three way stop are connected. So one will be the this thing we can draw the blood from the infant, and at the same time we can also push the donor blood, and this is the one of the procedures. And then the the blood product that we use for RHD will be RH negative or group O or ABO compatible and
Hello,
cross match.
Dr. Swati. I just
Yes.
want to ask few questions. Just go to
Yes.
the previous slide.
Yes.
Yeah. So you have here a umbilical venous catheter, and you're doing exchange transfusion in that, right? Suppose you don't get any backflow in the umbilical vein catheter, or you don't get umbilical vein catheter. I mean, how will do exchange transfusion?
We can also use the peripheral lines, peripheral vein.
But it's to collecting a blood is not that easy. Like to withdraw blood through peripheral vein will not be easy.
We can use umbilical artery, sir. Umbilical artery and the peripheral vein.
Yeah,
Can you use the
you can do
peripheral
that.
artery?
Yeah. If you don't get anything, no umbilical, anything from the umbilicus, not the arterial vein, then you can use the peripheral artery, okay, and the peripheral vein.
Peripheral, yes.
Okay.
Yes. So here we use RH negative, any blood group that has to be suspended in the AB plasma, because the AB plasma contains no anti-A or anti-B. And the choice of blood, the blood should have a hematocrit of at least 50 to 60, and that should be cross matched with the infant, with the neonate, and as well as the mother's blood group. And it should be negative for antigens determined by the maternal antibodies, and it should be leukocyte depleted and irradiated. And irradiation is not a compulsion for exchange transfusion, and it should be CMV negative, and it should preferably be less than 5 to 7 days old.
Okay. So now, just an interruption after here. So you said negative for antigen determined by maternal antibody. So which stage do we do for ensuring this?
Um,
To ensure that it is negative for antigens determined by maternal antibodies.
we do that.
We don't do that. So we are supposed to cross match with the mother's blood as well, isn't it? So we do
Yes.
cross matching with the infant's blood as well as with the maternal blood, and that would help us to actually exclude all these.
Okay. Coming to the blood volume, so we can use double volume or we can use single volume. So double volume will be 2 times the circulatory volume. So usually we take circulatory blood volume as 80 ml per kg in terms and 100 ml per kg in pre-terms. And double volume exchange will replace about 85% of the blood volume, and also it reduces bilirubin by 50%. And in single volume, 60% of the blood volume is replaced. And usually we don't do it in Rh negative. Some of the complications of exchange transfusion can be catheter related complications like air emboli, thrombosis, and hemorrhage. And also because of the hemodynamic instability like hypo or hypertension, and intraventricular hemorrhage can happen. There can be hypo or hyperglycemia, and there can be hypocalcemia, hyperkalemia, and acidemia. And related to exchange transfusion, it can be arrhythmias, bradycardias, neutropenia, and NEC most important, and feed intolerance. There can be septicemia and hyperthermia, like temperature instability also. And moving on to ACOG guidelines. So first is all pregnant women will be tested at the time of first prenatal visit itself for the blood group. And in case of Rh negative, they'll be screened for the presence of any erythrocyte antibodies. And the American Association of Blood Bank, it also recommends that we have to repeat the antibody screening before administration of anti-D immunoglobulin at 28 weeks and postpartum and any event at the time of any event in pregnancy. And usually we take critical titer. In most of the places, we take it between 1:8 to 1:32, and usually they take it as 1:16. And that actually holds a significant risk for severe erythroblastosis fetalis and hydrox.
Okay, just 1 second out here.
Yes, ma'am.
Yeah. So you said according to ACOG guidelines, in the first prenatal visit, we go for ABO blood grouping and the RSD type. And
Yes.
any other thing which can be done, maybe like it's not recommended by ACOG, but other guidelines like NICE guidelines recommend few other tests, and which has been mentioned already by Dr. Panigrahi. So, like, maybe you can tell us about that.
ICT.
No. So we go for cell-free DNA, which is also available in our country now. NIPT test, non-invasive prenatal testing, which she had already mentioned. So this is cell-free DNA in the mother's blood.
To detect babies'
Yeah,
blood.
to detect the baby's blood group. So if it is negative, then you don't go for further tests. Supposing the father is not available, or like it may be so that we do not know about the father's blood group. At times it might happen. At least in those conditions, we do have an opportunity of knowing the baby's blood group by doing this cell-free DNA. And NICE guidelines definitely says that the cell-free DNA should be tested after the mother becomes pregnant in the first trimester. But then this is done after 11 weeks of pregnancy. Before that, actually, the sensitivity is not very good. Then after that, it is being done. And then finally, like you would go for the other test.
Okay.
This is just another information which I wanted to give. Okay.
Yes.
Yeah, you can carry on.
Yeah. So once we get to know that it is, we identify the maternal antibodies, it comes positive, then we have to determine the paternal genotype, then the fetal genotype. And historically, they used to do spectral analysis of amniotic fluid to determine the bilirubin, this thing. But the current trend is management with MCA Doppler. So this was the spectral analysis of amniotic fluid that was done historically. So Queenan's curve we used to use in the early gestational period, that is before 24 weeks, and then Lily's chart we use it for the later after beyond 24 weeks, which is not used anymore. And anti-D
Can I go back
immunoglobulin.
to the previous slide?
Yes, sir.
Just because you told the Lilly chart will be used after 24 weeks or before 24 weeks?
Queenan's chart will be used in the early gestation period, sir. Lily's will be
Yeah.
used in the later, like second trimester to third trimester. Later
Okay.
part of second trimester, and then
Okay.
anti-D immunoglobulin is indicated only if previously not sensitized to the D antigen. Coming to the fetal Dopplers, So this is the non-invasive method and the current trend to assess the degree of fetal anemia. So here the Doppler picks up the peak systolic velocity in the fetal middle cerebral artery, and because of the peak systolic velocity, it correlates with the hemoglobin in the fetuses. So here we take the moderate to severe fetal anemia is we determine that if the MCA, that is MCA PSV, exceeds 1.5 multiples, that is MOM, between the gestational period of 18 to 35 weeks. So this test has about a sensitivity of 86% and specificity of 71%. And usually what happens is that if the fetal hemoglobin is typically less than 10 or the hematocrit is less than 30, it signifies we get MOM, we get 1.5 MOM on peak systolic MCA PSV. So if the HB concentration falls below 6 to 7, then the fetal hydrops usually sets in. So here we can see the this is the axial view. This is the axial image of the fetal brain. So here the circle of Willis is demonstrated, and just 2 mm from the proximal, from the origin of the MCA, the Doppler is usually placed, and we take the readings. And again, we have for that particular gestational age, we have a mean hemoglobin. And if the mean hemoglobin is less than 2 standard deviation for that particular gestational age, usually intrauterine transfusion can be done. So once we know that on MCA PSV, if that exceeds 1.5 MOM, then we have to do percutaneous umbilical vein sampling and to determine the fetal HB and fetal hematocrit. So if the fetal HB is less than 2 standard deviation from the mean hemoglobin for that gestational age, we have to go ahead with the intrauterine transfusion. So intrauterine transfusion can be done via 3 approaches. That is intravascular approach, intracardiac approach, and intraperitoneal approach. Intravascular approach is the most commonly used approach. So in case of anterior placenta, we can use the umbilical vein at its placental insertion. Or in case of posterior placenta, it can be done in the intrahepatic portion of the umbilical vein. And intraperitoneal approach is usually done in less than 22 weeks because of poor anatomical distinction. And then intracardiac approach is rarely done. And the prerequisites for the intrauterine transfusion, the blood should be, the cross matching of the donor blood with the mother serum must be done. And usually O negative packed RBCs are taken. And infection screening to be done for CMV, hepatitis C, HIV, hepatitis B, and also should be less than 7 days old. And gamma radiation should be done because to prevent fatal graft versus host reaction, and leukodepletion also should be done. And hematocrit should be around 75 to 80%. And a platelet should be made available in case if there is fetal hydrops. And this is the image. It will be ultrasound guided procedure. So once fetal MCA, once the intrauterine transfusion is done, the fetal MCA will have adult RBCs. So the threshold will increase for the second RBCs, which the earlier, which was 1.5, will be 1.69 now, because the adult RBCs behave differently than the fetal RBCs. So this is about the intrauterine transfusion. Coming to the albumin transfusion evidence, here we see that in this study, the participants were administered 20% human albumin. Only one trial had used 5% human albumin, but in practice, usually 5% human albumin is used if albumin is less than 3 gram per deciliter. And usually the dose that we give is 1 gram per kg body weight. And here what happens is intensive phototherapy also can cause photooxidation of albumin, and that's why it reduces the albumin, this affinity that inhibits affinity of the binding of bilirubin to albumin, and this can cause neurotoxicity. So albumin infusion is recommended because pre-albumin infusion can also reduce the need for repeating ET, and it shortens the duration of phototherapy. Coming to the evidence of IVIG, the proposed mechanism for IVIG was inhibition of hemolysis by blocking the antibody receptors on RBCs. So the dosing was somewhere between 500 mg to 1000 mg per kg, which is usually given over 2 hours. And if necessary, the dose could have been repeated. So the indications were for jaundice neonates with antibody-mediated HDN and severe hyperbilirubinemia who do not respond to intensive phototherapy. IVIG is sometimes administered, and when the total serum bilirubin is increasing despite intensive phototherapy, and if it is less than 2 to 3 mg of mg per deciliter, less than the threshold for ET, it can be given. IVIG can be given. And efficacy, coming to the efficacy, it did not decrease the need for exchange transfusion or the need for RBC transfusion, and it did not even decrease the mean serum bilirubin levels. And in neonates, it's not recommended with low certainty of evidence. And but some studies with moderate certainty of evidence suggest that the early administration is not effective. That is, the prophylactic administration of IVIG also is not effective. So usually this is the
Just Swati, one point here, because
Yes.
these two important evidences you now spoke actually very, very relevant.
Yes.
The guidelines are not agreeing sometimes. The international guidelines little different. So albumin, you say if you will come to AAP guidelines, it won't recommend. But you will come to NICE guidelines, still it discusses the debate. It discussion happens with albumin before
Yes.
the pre-sensitization of albumin before the exchange transfusion, because the concept is to let the albumin bind to the bilirubin before the exchange, and it removes a lot of bilirubin when we exchange it.
Yes.
So that concept theoretical advantage, but the clinical evidence is not proposing us to use it. But coming to IVIG, there are many international guidelines are there, but a compilation of all international guidelines about IVIG. Probably you are aware of the evidence, which is generated a meta-analysis review done, compiling all things. There is you highlighted. We want to highlight again preventive. Preventive means before the challenge comes,
Yes.
before the severe hemolysis evidences in the form of jaundice, which is refractory to primary treatment of phototherapy.
Yes.
We are not recommending in either Rh negative HDN or in case of ABI incompatibility. Both the cases, primary prevention IVIG, there is very clear evidence says that it's not useful to get to prevent the further complications or the efficacy relevance to efficacy means it won't increase the efficacy of phototherapy so that we can prevent the transfusion. But cases of when it is refractory, rapidly increasing hyperbilirubinemia, irrespective of the primary therapy use of phototherapy, those cases the evidence still hanging. The pendulum is still swinging both sides. So standard recommendation, not agreement is not across all the guidelines. Says there speaks individual case basis. If there is a phototherapy after giving also the bilirubin is rising so much that is reaching close to 2 milligram below the exchange zone, you can use with evidence of hemolysis, you can use IVIG. So
Yes.
that's the current recommendation. So saying sentence yes or no, it will create a confusion. Statement is primary prophylaxis like start immediately you got evidence from umbilical cord blood, DCT positive, RS setting is there, use it. Or ABO setting, DCT positive, use it. That's not the recommendation. Very clearly you stated. I'm happy that you took the evidence and clearly stated. Other part, if we rapidly increasing hyperbilirubinemia, irrespective of phototherapy, there is a question comes.
Yes.
In evidence with evidence of hemolysis, we can still use it.
Yes.
Though we are aware IVIG causes hemolysis, IVIG causes NEC, but those are more and more so in compromised, hypoxic and premature babies. In bigger late preterm and term babies, those NEC hemolysis evidences are lower. So when there is needed, can be used. So this is probably your recommendation. Your evidence is only I used, and I'm just again reinforcing your statements, and you can proceed further. Whatever remaining presentation.
So usually we use 1 gram per kg. So this is the what we use here, 5% solution, 5 grams is what we use. Here we see that there is IgG 5 grams, and it also has IgA content. That is, usually it should be less than 80 mg per deciliter, because 1% of the population can be IgA deficient. So in order to prevent any anaphylactic reaction, we have to be careful that we check IgA content and then transfuse.
So
And
clarify one thing, this product probably we don't in platform we endorse any of the generic thing you can use if you feel. But this
yes.
product for the picture sake, representation sake, but we don't endorse in the platform any of the commercial
Yes.
products.
You can
Yes.
blur actually the names and other things. I expect.
Okay. Okay. Sir. Next is the CDC guidelines for vaccination post IVIG. So usually what happens is we can give typhoid vaccine, that is the nasal route, and then we can also give influenza vaccine and rotaviral vaccine, despite being live vaccines after IVIG. But usually there is and whatever the measles and rubella vaccine should not be given for at least more than 3 months. So the CDC guidelines right now says that if you are giving 1 gram per kg IVIG via IV route, you have to give MMR vaccine after 10 months, and 2 gram per kg IV should give after 11 months.
So do you think, Dr. Swati, this is relevant to the neonatal IVIG use in the exchange transfusion prevention or phototherapy after? Because this MMR vaccination in India, when we give normally?
9
If a
months.
pediatric sepsis, somebody use IVIG, this recommendation holds true for 3 months age. But a baby newborn, when newborn regarding the BCG, hepatitis B, polio, or the DPT rotavirus, do you think any contraindication? Because
No, sir.
polio is a live vaccine,
No,
rotavirus is a
BCG.
live vaccine, but that's not contraindication. So I'm just clarifying because we are talking a neonatal case presentation. In neonates, when we use first 3 months, these are the MMR and varicella like live vaccines are not a clinical scenario. So, but a same baby pediatric practice, a 6 month old baby or a 5 month old baby, we are using IVIG. We have to keep in mind next 3 months we are not going to use any live vaccines post IVIG. That's probably your message. I want to clarify, just to clarify, because neonates, BCG is a live vaccine, polio is a live vaccine, and rota is a live vaccine, but those are not contraindicated in cases of IVIG.
Yes, sir. And coming to the new concept, that is home phototherapy. So, according to American Academy of Pediatrics, this can be indicated if the infant has neonatal hyperbilirubinemia, who is ready to be discharged from the hospital, is already discharged without any neurotoxicity risk factors, and if the total serum bilirubin concentration is not more than 1 mg per deciliter, above the phototherapy treatment threshold. So here for home therapy, we usually use the fiber optic blanket or the band, as we can see in the pictures. And coming to the intensive phototherapy, here we can see the spherical one, where from or multi-directional we can see, and here also the undersurface will also be uh, also is a phototherapy unit. So intensive phototherapy is when the narrow spectrum LED blue light with irradiance of at least 30 microwatt per centimeter square per nanometer at a wavelength of around 470 to 490 nanometer is known as intensive phototherapy. So
Have you finished your presentation?
yes, sir. Yes, sir. So
So,
the
any
discussion.
questions? Yeah, yeah.
Yeah, that has been a good presentation actually. Some other things which like I think we need to emphasize is regarding the delayed cord clamping in the labor room. So there
Yes.
is no contraindication of delayed cord clamping in Rh negative pregnancy. So that is very important for us to know.
Yes.
Then one thing which I would like to again emphasize from my side is that the NTD which is being given to mothers may not be adequate to cover the fetal-maternal transmission at times. So ideally, we should be doing certain tests like Leber-Betke test, which is not available all the time, but we need to be aware of that. Because as we have seen in your patient, although the first pregnancy was not affected much, and then like she just had jaundice needing phototherapy, but a subsequent pregnancy, despite mother receiving NTD, there was the need for exchange transfusion, that too twice. So ideally, I think if we all should know that fetal-maternal transmission, like maybe more than what is being covered by the 300 microgram of NTD. So this 300 microgram is adequate to cover 30 ml of fetal-maternal transmission. But if it is more than that, then despite receiving this NTT, mothers may become immunized. Then other thing which I think we need to understand is regarding the cell-free DNA testing. So where facilities are available, this can be utilized to know what may be the blood group of the fetus as
Yes.
early as 11 weeks of gestation age. And regarding your middle cerebral artery Doppler, this is being done only after 15 weeks of gestational age. So
Yes.
before
18 to
that, the
25.
sensitivity and specificity is very poor.
Yeah.
So you start with the cell-free DNA when it detects that there is a positive baby, then you will be serially doing the NTD titer monthly till 24 weeks, then every 2 weeks. And when it is more than 1:16, as you have already mentioned, then you will go for middle cerebral artery Doppler, isn't it?
Yes, ma'am.
Yeah. And then when it is more, this median of mode is more than 1.5,
We have
then
to fetal
we'll go
HP.
for fetal hemoglobin estimation. And then finally,
Hemoglobin.
like if it is 30 or less than that, we'll go for transfusion.
Yes.
And in that case, if the baby has been transfused, then we wait for delivery for more than 3 weeks after the transfusion. In case the median of mode is less than 1.5, then these babies are delivered earlier because they have not been affected. So like by 35 weeks, usually they
They'll be
would be
dead.
delivered, yeah, rather than allowing them to get immunized in utero and then suffer from anemia. So like extrauterine survival rate would be better for them. So I
Yes.
think like this is how we would be doing. And then in the labor room, we need to be prepared to deliver these kind of babies. So what are the things that you think we should be, preparing ourselves with?
In case of RH negative, ma'am.
Yeah, in the labor room.
Yeah, DCC can be done for the baby.
Yeah, DCC can be done. Yeah.
In case of fetal hydrops, if there are any, if there is fetal hydrops, then we have to do active intervention.
Yeah, so provision for drainage of peritoneal fluid or
Yeah.
a
Yes.
fluid
Pericard,
or
pericard
pericardial fluid. Yeah, so those should be available to us, isn't it?
available immediately.
Maybe a person who knows how to intubate should be available because that baby would be needing intubation quickly. Yeah. And then also there should be provision for blood already.
Yeah.
RH negative blood should be available because
Should be
this
kept.
baby probably would be needing exchange transfusion. So this preparation is very important, I think.
Yeah, Dr. Swati, it's actually a fantastic, very good presentations. You have compiled all those evidences, and there are a few controversies still remain, like what are the dose of anti-D to be given? I mean, that should be adequate dose. I mean, it's not a controversy, but you have to be very. You have to know that. I mean, how much dose to be given to
Yes.
neutralize the antibodies. Then IVIG. I mean, still, previously everybody was suggesting to give IVIG, but recently, I mean, we found out that it may not help in this such kind of babies. So very nice, very good presentations, and
Yes.
all the best. Yeah. Any other questions from the audience? And I think somebody wrote there. I saw somebody that is how you give the for exchange transmission, how you prepare the blood, because as per the recommendation, you know that. I mean, it should be a
It's
like O
RH,
negative. Yeah.
O negative, and that should be suspended in AB plasma. So that should be two-thirds and one-third.
Yeah.
Two-thirds of the blood component, one-third of the plasma component.
Yeah.
Mhm.
Correct. Yeah.
Dr. Swati, you can stop sharing your presentation. Few things we will take questions if it is there. One thing I will, per your presentation, I saw is very good, well addressed many of the issues. I congratulate you and Dr. Prasanna. The Cloud9 team agreed shortly to present and covered all many of the aspects with the evidence. And at your level, giving evidences for the practices is very, very important, and which you have done well. And the case throughout the journey of the case, what are the challenges, how you handle that, very well presented. Just I will request you to highlight one of the Rita Bora madam is saying all 2 to 3 times I heard here the anti-D which we are giving, the dose is different antenatally and postnatally. Why it is so? Because the point is to neutralize the bleeding which is happening at the interface of the placenta. So for that reason, we do the KB count. So can you, for the clearance and clear understanding of the audience, can you clarify what is KB count, how we do, how we interpret, and how it helps to decide the dose of NTD? The dose of NTD, we are empirically saying 500 units or 100 microgram or 1500 units, 300 microgram. That's empirically. But if I want to know, there is evidence abortion happened, ectopic pregnancy happened, there is RH negative setting. Now I have to prevent in the later those hemolysis. How to decide how much to give the dose? That's the
Usually,
KV count cells.
yes, sir. Usually, what happens is 300 microgram will be sufficient for about 30 ml of um, hemorrhage that has happened. So we have to find out using the formula that how much ml of blood is I mean hemorrhage has happened, and then based on that we have to decide the dose, sir.
How the KB count helps in knowing how much fetal blood loss in the mother's inside the mother, because it's a feto-maternal bleeding. So how much
Okay.
the fetal blood entered into the maternal circulation, that decides the dosing. And are
Yes,
you
sir.
aware? Otherwise, I can explain actually. Are you aware of the formula?
I'm not aware of the formula, sir.
Fine, perfectly fine, not an issue. But KB count, many places not available. But if you'll ask regularly our pathology department, and simply they can do. Many of the places they do. So first of all, we have to see that how much percentage of fetal RBCs are present in a maternal peripheral smear. If I'll say, if RBC count I am doing, 2% or 1% are fetal RBC, and remaining 99% or 98% is the maternal RBC. That first point is decided by the KB count. Once we know that that percentage, multiply with 50, 50. If 1% fetal blood multiplied by 50, 50 ml fetal blood lost to the baby, lost from the fetus side to the maternal side. You peripheral smear, you counted, the KB count says 2% fetal RBCs are there, 98% maternal RBC. 2 multiplied by 50. So 100 ml blood loss is there. Now you know the amount of blood loss. From there you calculate. You told me 1 ml required 10 microgram of NTD. You only told the answer. Now you know the blood. That much you calculate. So exactly we neutralize. If improperly or inadequately we neutralize initially, what will happen later? Then again possible hemolysis or DCT positivity, still ongoing hemolysis will happen. That's
Yes.
one question. So I thought I will clarify, because it is many clinical uses there can be count. Still, it's relevant, and many centers do hematology units. Wherever the hematology or pathology units are there, they still do. May not be available across country, but many centers they do. We can use it as simple test. And second point, I'll say you discharge the baby now, given IVIG, hemolysis is going on, and exchange transfusion done. For the further follow, how much duration, how many months you are going to follow the baby, and what precautions you will take for the baby.
Sir, we have to give folic acid has to be continued till 6 weeks, and then we have to see for the developmental milestones of the baby, sir.
No, developmental later. For development, I like your developmental answer, but that's later. But immediately for the hemolysis in the blood, what things you will suggest to the family? How to do the follow up, how frequently? And
So
because still the hemolysis may be ongoing after
yes, sir,
exchange transfusion also.
we do weekly CBC for the first 3 weeks. Then we do every second 2 weeks.
Okay.
CBC
So
will be done.
few weeks, at least 6 to 10 weeks, the goal is to monitor the hemoglobin, because hemoglobin, the jaundice may not come back again, but the mild hemolysis and anemia may be a consequence till next 3 months. So to follow at least 10 weeks to 12 weeks, that's the guideline. And why you are repeatedly saying you will give folic acid, but you are not interested in iron?
So, iron and folic acid. Yes.
So iron, because hemolysis is going on, iron usually it is
Overload.
rare to extract from the body. The same iron will be reused. You are right in saying folic acid. So iron dose may be like a maintenance dose, but actually the iron which is already from hemolysis used in the body, if you will estimate the total iron and serum ferritin in a post hemolysis, post exchange, usually it maintains well. So the iron will be reused, and folic acid for a nucleotide synthesis you will require. So you are right only, but I'm saying for one half life of RBC. So if you are saying 120 days RBC, at least 60 days, 2 months, we should do the follow, and we should complete the supplementation. That's you're right only. Just I'm highlighting the facts and explaining. So the practice, when we know the answer, our practice will be more strengthened. Okay.
Yeah, actually, we will be giving blood transfusion also. So iron load would be increased in the body. So ideally, we should be looking at the serum ferritin, and only once it is in the normal level or goes down, then we start with iron. Otherwise, we would not start with iron.
Perfectly. So one question about hemolysis. Somebody's asking, can the cycles can be changed? But we normally suggest you customize exchange transfusion to avoid different people do different practice. But we always say, okay, reconstitute from plasma. The way you explain 2:1 plasma and LRBC, liquid depleted RBC, preferably. If not available, packed RBC. But wholesale, we always suggest not to do. And what about the irradiation? Do we do irradiation? Is the guideline says do irradiation for the exchange transfusion?
Exchange transfusion, that is not a compulsion, sir. But intrauterine transfusion, irradiation is a
Very
must.
good. Very good. Is a must. So that's a must actually. So we cannot avoid irradiation in utero when we are doing intrauterine. But cases of postnatal, it is not mandatory. If the facility is there, you can go ahead. Not issue. Okay. So with this, probably we see a lot of practice question we answered. And I'm thankful to Dr. Prasanna, the faculty, local faculty moderator there in the Cloud9. And sir, can you, if you want to pass some messages, learning points to the audience and students are listening, you can pass some message. Then I will request both faculties to close the session.
Thanks, Dr. Nalinikan, for giving us this opportunity. Dr. Swati has presented very well. I will add a few points which we come across. One is BCC, we have mentioned already. There is a clear-cut evidence. Then sometimes what fellows need to know, when we do the intrauterine transfusion, if it is done in the few weeks prior to the delivery, when you check the baby's blood group, that will reflect transfused blood group. That we have seen couple of times. When you ask the fetal medicine team, they say it is a normal phenomena. Just be aware, blood group of the baby after the intrauterine transfusion, you will get transfused blood group. So it will be negative. Even the baby is positive. So that happens. We have seen a couple of cases. Then afterwards, it will come back to usual baby's blood. Don't get confused. Another thing, this baby never had eye drops. Otherwise, sometimes if baby is decompensated, then we will have a tough time. So you should prepare for the high risk delivery, how to resuscitate a eye drops baby. So luckily this was handled very well, but sometimes we come across. But fellows, what they need to know, if you get eye drops baby, that means we have allowed the fetus to decompensate. Then mortality is going to be high. You can resuscitate very well. Still, it comes with mortality. So you should act before baby decompensates, before the anemia kicks in. So now in cities we have very good fetal medicine team. They give the intrauterine transfusion. They give us the baby in a better condition. But sometimes that is not the case. Then there are a couple of questions regarding the IVIG and live vaccine. So there is interesting concept. See, now only the MMR is the one which is going to be affected. That's why 1 gram is for 10 months, 2 grams are for 11 months. But we give BCG, OPV at birth. They are live vaccine. Why we are giving a live vaccine on time? There is a reason. Now BCG is acted by the type 4 hypersensitivity, cell mediated immunity. So this whatever immunoglobulin is there, it's not going to affect the BCG reaction. So you can give BCG on time because the pathophysiology is totally different. Then rotavirus is also live vaccine. Why are we giving live vaccine on time? Because rotavirus mainly IgA dependent. It is nothing to do with the IgG. So you can give rotavirus and BCG on time. It will not interfere. But you should always avoid MMR for 10 months or 11 months, depending on the how much you have given the IVIG. That is because the measles measles response is going to be affected. That is the studies have shown. But here we have given IVIG, then we do the exchange. So some of the Immunoglobulins we have removed anyway. That people can debate. That is one. Then most of the points she has covered actually.
Sir, it's a
Then
good thing that you talk now the live vaccines, you clarify doubts, and I will again request you. One of the question came from the audience. Again, BCs regarding specific questions came. So if we clarified the MMR and varicella is late, we are not worried, and MMR already very much cleared the MMR practice. But a question came out regarding BCG. So BCG regarding if you have already exchange transfusion done, IVIG given. So the day one only you started, you did not get an opportunity to give BCG. Can you give BCG without delay or with some delay required? That's the question. So,
no
so
need
you
to
could
delay.
clarify
No
that
need to
question
delay.
also.
Because that is the answer.
So actually, that's the recommendation. I will say that one clarify when hepatitis B positive mother, we give immunoglobulin, hepatitis B immunoglobulin, along with hepatitis B. That time also there is no delay in the BCG. If you're giving immunoglobulin therapy, there also should not be delay in the BCG. Even the same day we are not able to give without much delay. Next 24 to 48 hours we have to complete it. There is no gap recommendation for the BCG. That's the standard recommendation. It is in the BCG individual vaccine recommendation in CDC, it is written without delay, we can go ahead. That's probably clarification for the trainees.
Now, other issue is whenever you use IVIG, there are a few preparations available. Always make it a habit, check the IgA level. So if IgA level is low, that means it is a better quality. It is going to be costlier. So in India, I have checked it is less than 80 for 5 grams. But in US and all, it is less than 20, something like that. So it is more purified. So otherwise, if we are unlucky, then there is a chance of anaphylaxis reaction if baby is having IgA deficient. That is less than 1%. To reduce that risk, people there is a guideline. They should reduce the content of the IgA. That is one. And another one is whenever you give phototherapy, now most of the units we are using LED lights. So before we used to say 45 centimeter and all, that is no more valid. You just keep the light nearest to the baby because LED light is not going to affect all the thermal regulation and all. It is safe nearest to the baby. Then normally parents will ask what is the effect of phototherapy on long term. So there is some observation studies have shown there is a slight risk of childhood epilepsy with the phototherapy because of all the and also some slightly increased risk of cancer because it damages the DNA. So that risk is there, but it is not causative association. So be aware. Some of the observation studies have shown the childhood epilepsy has gone up slightly. Those who have received phototherapy.
Very good point, sir. Dr. Swaroop, do you have any message for the trainees? So we probably Dr. Ritabara madam logged out, and you can have some message before closing the session.
Yeah, it's actually a very good presentation. I mean, everything was been properly explained in that, and after the discussions, everything has been explained very nicely. A few things I want to tell you that's RSI immunization definitely should consider it as a emergency situations because I mean early interventions can prevent the long term and the short term complications. And there are a few gray areas where use of IVIG and other things you have to consider when to give and when not to give. So definitely antenatal, I mean the treatment should start in the antenatal period itself. I mean there is other indication that if there is some maneuvering done in the antenatal period, ectopic pregnancies and abortions, maybe sometimes you have to give anti-D to the mother in that case. I mean where we suspect that fetal-maternal transfusion has occurred. So very nice presentations on early interventions and treatment and will prevent the long-term complications. And congratulations, Dr. Swati. Thank you very much for such a nice presentation.
Thank you, sir.
Thanks,
Thank you.
Swati. Well, presentation. Well, all age faculty, all faculties are appreciating you. Presented well from antenatal to follow. We covered probably everything.
Thank you,
And
sir.
I just wish you a happy learning further throughout your fellowship session. You must be with a great company and learning. And so this with this session, I thank Cloud9 team again for presenting such a nice case for learning. Everybody's learning. I thanks Dr. Prasanna for taking it very enthusiastically and guiding the student. And equally, I thanks for today's session, Dr. Swaroop and Dr. Rita Bora ma'am, who actively participated and guided in the few of the learning session. So I thanking all of you. I'm going to close the session today, but I'm requesting all the delegates and trainees to attend next session, which will be not a case presentation, a faculty talk by one of the eminent faculty of retina faculty, who is going to present the current recommendations of retinopathy of prematurity, the preventive methods and the diagnostic methods and its challenges, and the basic layout of the management. This next week, we are going to have a guest lecture on ROP. Please, all of you join that next time. Thank you all. I'm closing the session. Bye.
Thank
Good
you.
night
Bye.
for the
Thank you.
today.
Thank you very much.
Bye-bye.
Bye-bye. Bye-bye.